She looks unfamiliar. It's because you are probably, right? You're just new?
Me.
Okay.
Simone, one of our great assets in ICU. She's palliative care symptomatic.
She is the palliative care.
And this is-
One of the attendings.
Yeah.
We met, I met Tasha.
Yes.
Welcome to Winnipeg. It's usually not this hot, but now we got rain and it is.
I was in -40.
I was whatever, and I'm 30 year.
I have 30
Hello.
in my house, I'm good.
Yeah, it functions, it's all.
There should be a baby attending here. Hi, Rihanna.
Yeah.
Okay.
Hi.
Good girl. She'll be a neonatologist. Okay.
Say hi with my coworkers, baby.
Okay. So you want me to
Sorry.
start, Ayman?
I think you can, of course.
Okay.
Thanks,
All
Rebecca.
right. Okay, so I will start.
Yeah,
What do you need?
we're good, just turn down the
Oh,
light,
okay.
good lighting.
Oh, okay. All right.
There we go.
So as you know, the topic for today's Fellows Academic Day for this hour is neonatal palliative care. And I'm very honored and happy to be asked to give this presentation. Of course, I'm also horrified. And I'm very happy that I am with Simone from Palliative Care. As far as my book is concerned, she is the palliative care person, go-to for us. Okay, so she's been very helpful in the preparation of this talk. So I will start. You see all her titles there? RN, MN, CMHP, CNC, and palliative care nurse. So, and present. So I will start with the format or the objectives of this talk is first, we will talk about two cases. I'm talking about a shorter case that lived for 12 days. And Simone will talk about a more complicated, longer case that starts from antenatal to neonatal to discharge home to death. So that took about over 2 years. We ask that you ask your questions later because it's high, because of the length of the case that Simone will discuss. I'll give you a brief introduction and review of the topic. Then there will be discussions, and I will be mentioning protocols and guidelines. It's a long list, and then there's Q&A. Okay, case number one. This baby stayed in hospital for 12 days from January in the winter, middle of winter, 12 to 24 of this year. Some of you may recognize, well, you will recognize a term male infant, 37 weeks, birth weight is 35-30, Apgar 7 and 8. Pretty common scenario, right? But, and the family is from Winnipeg, but the mother, who is 29 years old, with serology protective, had an antenatal diagnosis of congenital heart disease. I'll talk about that more later. She was delivered by C-section because of breech presentation. And initially the baby needed CPAP and then needed to be ventilated. The main issue in this baby is the complex inoperable congenital heart disease. He was seen by pediatric cardiology immediately, and they found all these things: ASDM, aplastic right ventricle, tricuspid atresia, etc. And they had asked for a CT angio. The CT angio just confirmed the inoperable congenital heart disease. There was tricuspid atresia, pulmonary atresia. Left pulmonary artery was supplied by MAPCAS. no significant main pulmonary artery, and aberrant pulmonary drainage. There's also et cetera in here. Okay, it's too long. Other issues, hypoglycemia, hyperglycemia, common things in the NICU, hyponatremia, hypocalcemia, needed TPN and got minimal enteral feeds, lines, UAC, UVC, which was slow and removed and replaced by a PICC line. Oh, wrong spelling. Vertebral anomalies were noted in the CT angio. There was segmentation, so there was some scoliosis as well. Genetics was consulted because the baby had dysmorphic features as well. And these dysmorphic features included small ears, low-set ears, micrognathia, clenched hands, single palmar crease, short neck, etc. So their first differential is suspected diabetic embryopathy. And of course, they had other differentials such as trisomy 18 because of the clenched hands, but that was ruled out by chromosomes. They were also thinking of bacterial and other chromosomal problems that we all know by heart, right? Okay. Continuing on, there were discussions, meetings with the family. I will just make that short. The initial ACP was M, which means do all the medical things, but do not resuscitate. And then eventually they agreed to ACP-C or comfort care. Of course, palliative care service was consulted right away, and they were involved from the beginning to the end. There's a mention of memory box, family photos. And on January 21st, at the age of 10 days, the baby's prostaglandins were discontinued, then extubated at 1450 in the NICU. Glycopyrrolate was given 1 hour prior and was also receiving fentanyl and midazolam prior to extubation plus PRN doses, so comfort measures. January 22 to 23, the baby was still in the NICU, and on the 24th, early in the morning at 5:44, the baby expired. The parents declined PM. I will give the floor to for the second case.
And also wanted to show you a bit more of a broad case for one of them from our perspective. So this second case is a prenatal diagnosis of a male fetus with Joubert syndrome. He also had encephalocele, which had meninges only. He had a Dandy-Walker cyst and bilateral enlarged echogenic kidneys, which 3 days prior to delivery, they looked and saw that he had normal amniotic fluid. He was seen by fetal assessment, obviously followed closely there, seen by genetics, neonatology, and pediatric palliative care. And actually, this was a rare one because recently we've actually done a lot of our prenatal consults together in terms of neonatology and pediatric palliative care together. And I don't know why, I think neonatology was just consulted first. And so they had seen the babe and had already done their assessment. In terms of family background, they are a religious family. They live on a Hutterite colony, so they're Hutterite descent, and they have one older child. So the family prenatally said, they wanted short-term interventions that could help to support their son and stabilize him. They would consider ventilatory support and feeding support if it was required. But really, they were very realistic in terms of, they said, if there's a point in their son's life where it becomes apparent he couldn't be off of machines, they said, then we would stop those interventions. So they were very much like we would use them for short term to try and get him home or to try and get him past a difficulty, but that they would consider withdrawal of life-sustaining interventions. So that's a very, I felt like a very balanced approach prenatally in terms of how they were dealing with things. I find that often with the Hutterite folks is that they're very pragmatic, so that they are very much, yes, let's try something, but if it doesn't work, then let's stop it, right? So they're very, very good at being able to see what can be of benefit and what might not be. So, so they would want invasive interventions right after birth. and then make decisions moment by moment, which isn't always what teams like to hear. But I think, when there's lots of uncertainty, especially with how that encephalocele would be doing and how that would impact him, it is sometimes that moment by moment decision to see how vigorous is this baby. Does it make sense to put them on supports? So they also made very certain that they would not want him on machines for his whole life. So that was really a helpful sort of perspective. So prior to delivery, actually his occipital encephalocele, trying to say that 5 times, was drained twice for about 300 mLs each time so that they could facilitate a vaginal birth. So what happened after delivery? He was taken to the NICU. Day 2, he was intubated and ventilated. Day 5, he went for surgery, and there was no brain tissue herniation into the sac. So he actually did reasonably well. On day 7, they had to have a VP shunt for him because he developed hydrocephalus. On day 10, so this was actually really quick, parents were like, okay, that's it, like take him off machines. And everybody was sort of like, but like, we're not quite there yet, right? Like everybody was just, and everyone's okay, fine, if that's what you want. So he did have some very periodic breathing, but then that seemed to resolve after a few hours. And then the next day, after like he had just been extubated, they're like, we want to get home because we want to go swimming with his brother tonight. Like that's like, it was just like, get us out of here. And he was NG fed. And so we were doing like teaching and like literally like running out the door for them, right? Because it was like, oh, we hadn't expected that from from extubation to the next day being out of here. So it was a rapid discharge, I would say. But they had very clear goals of care. They wanted ACPM, so no further kind of escalation in terms of resuscitation. They knew that it was very difficult to predict his prognosis. So what we actually had was developed a care plan for a palliative care plan. We had a letter of anticipated home death in place. We involved the palliative care nurse who was in the southern region, which is where they lived. And they started doing consistent visits, home visits, because the family really didn't want a lot of follow-up at that point in time. They just wanted to minimize it so that they could be home if he was going to die at home. And then they had a pediatrician who was spectacular and kind of kept in touch initially. And then after a while, everybody kind of kept keeping them in the background in terms of neurosurgery, neurology, feeding, SCI, which is specialized services for children and youth. And then also our palliative care team, we would see him if he was in Winnipeg, and the rural folks kept following him. So fast forward to like 2 years later, and he's still at home. And I think to everybody's surprise, and then, so he had initially been followed really closely by palliative care, and then less so, really continued to be followed by his primary pediatrician and the feeding clinic. He'd been doing well. In June 2022, he had a shunt revision. And then in terms of the information that I could glean from our charts was that in the 2 days before his death, he'd been struggling a little bit with some cold symptoms, and he was having apnea during the day, which wasn't normal for him. He did have apneas at night. And then he died during the night. And when mom went to check on him, he had been alive at 3:30 and then had died during the night when she went to find him deceased in his bed. And then they called the palliative care nurse and stayed at home. So very different than what you would see here, but also intense involvement of the NICU early in his life. Back to Meg.
So just to shock you with the enormity of this topic, I looked at PubMed. If you just put palliative care, you get 100,000 hits. You look at pediatric palliative care, you get 7,000. And if you get neonatal, there's still 3,000. That's still a lot of papers published on palliative care. Well, let's go to our favorite Google. Just put palliative care, you get millions, 144 million articles. Pediatric palliative care, 28 million. And guess how much neonatal? Still in the millions, 7 million. So it's a huge topic, difficult topic, complicated, sad, And we all need education, how to cope with this problem. So, okay, I then ended up with a list of things we need to know about, okay, that are important for us to learn. So the first on my list is what WRHA has. September 2009 was the first time this was published. It was a center-wide nursing education program, and it's quite extensive. In fact, I reviewed this a few years ago for the PIDS residents, and some of the slides are actually remnants of that presentation. Then this is the new one, and this is Neonatal Palliative Care Resource made or authored by our dedicated nurses. There are 5 authors of this one. It's Sandra Nickel, Morgan Kinley, Jen Kroniak, Natalie Hugh, and Rian Del Monte. And they also say thanks to the St. Boniface NICU End of Life Committee. So, plus there are many other contributors for this document. So I recommend that you read it. It's in the shared drive. You can pull it up. It is only 26 pages, and it's quite detailed. And there's 2 appendices, Appendix A and B, and there's references, of course. Okay, but this will be the subject of another discussion, Natasha, right? So we will, the objective is to provide resources to nurses and families when caring for neonates during palliative and bereavement situations. So thanks to all the authors, nursing, and the other contributors. Now I have to mention Canadian Pediatric Society. So these are the position statements that I can find. First is medical decision making in pediatrics from infancy to adolescence. That was in 2018. I actually read this and it's quite long, okay? There's also this thing called MAID, Medical Assistance in Dying, a Pediatric Perspective. Keep in mind that there is a bill in Canada, Bill C-14, which is made for adults. And it really, they're still looking at pediatric age group, okay? But they do some surveys of pediatricians about MAID, and it's in this article. Advanced Care Planning for Pediatric Patients, they have a statement on that, 2018. And then supporting and communicating with families experiencing a perinatal loss. There's a practice point that is also an important thing to have. Then, okay, let's not go here. Counseling and management for anticipated extremely preterm birth. This was in 2017. As Fabiana will attest, there is also a lot of literature on this because they're now resuscitating 22-weekers, and Fabiana put in a lot of work to come up with a protocol for us. Thanks, Fabiana. But let's not go there today, okay? Then there's also a paper on withholding and withdrawing artificial nutrition, which means gavage feedings or TPN, and it has become acceptable in 2012. It's still controversial, but acceptable. Now, let's go south of the border, our American neighbors. It's even worse if you go to American Academy of Pediatrics. There are at least 450 publications, and some of them are books, some of them are articles, and I just picked a few. There is one book chapter in the book called Guidance for Pediatric End-of-Life Care, and that's recent, April 2023. Then the AAP, American Academy of Pediatrics, endorsed the ACOG, which is American College of Obstetrics and Gynecology, publication of Perinatal Palliative Care. This is also available. And then on the section of Hospice and Palliative Medicine, April 25 of 2 months ago, they published this, Pediatrics and Palliative Care, 75 Years of Optimizing Healthcare Delivery. So you can see there's a long history. And I will just mention a few things about palliative care. What exactly is palliative care? Well, it comes from the Latin word palliare, which means to cloak. And palliative care, as we know, focuses on the relief of symptoms, pain, and stress of a serious illness, whatever the prognosis is. Oh, I went back. The WHO definition of palliative care, that's another long document. And I have 2 slides at the end defining what is palliative care and what is pediatric palliative care by who. I didn't want to put it here and I might put you to sleep. Okay, now for the discussions. Well, I mentioned again the WRHA, the Advanced Care Planning. You're all aware of this, the neonatal palliative care, the new one that I talked about. Well, the first one with WRHA was 2008, now it's 2023. That's good that it's updated. It's actually quite impressive. They even have pictures of how to go to the morgue and how to contact the ME and all these things. So very good. And of course, pediatrics, younger patient than the adult counterpart. And in the late 1970s, this would be 50 years ago, they acknowledged that children facing death have specific needs. And in 1982, Whitfield and Silverman initiated the hospice concepts to neonatal care. So it's been 40, 50 years ago that the literature had started to build up. Well, I will mention again, active total care of the child's body, mind, and spirit, and giving support to the family begins when the illness is diagnosed. It continues regardless of whether or not a child receives treatment directed at the disease. And multidisciplinary approach is the best approach. It includes family, of course, and available community resources. So I see here Lorelei, she's a spiritual care, so they are very much involved in this program also. The elders of the First Nations people, they're also involved and can be successfully implemented even if the resources are limited. Palliative care, Simone will talk about this more. It can happen in tertiary care facilities, in the community health centers, and children's homes. And it improves the quality of life of patients and families who face life-threatening illness by providing the following: pain and symptom relief, spiritual support, psychological support from diagnosis to the end of life and bereavement. Includes all the following in summary: relief from pain and other distressing symptoms, affirms life, and regards dying as a normal process. So death is part of life. And intends neither to hasten nor postpone death. So that's very difficult. Where's the balance? You don't want to prolong the agony, you don't want to rush the death either. So it's a balance. Integrate psychosocial and spiritual aspects, very complicated, as Laureline would know, and offer support system for the patient, live as actively as possible until death. This is adults, but you could extrapolate that to babies too. Support system to help the family cope. Simone will talk about this some more. And there's always the team approach. We are a team. We cannot work alone. We need to work together to come up with what's best, quote unquote, for the family and for the patient. And I've said that already. It is applicable early in the course of an illness. And in the case that Simone presented, early on, even before delivery, the problem was already identified. Okay, considerations. When do we talk about palliative care? Well, we start antenatal. Congenital abnormalities incompatible with life. Born at the limits of viability, let's not go there. Because now we're getting to 22 weeks, and that's a big topic, really, a really big topic. But just know that we are going for 22 weeks in this hospital and in the other hospitals in Bonaires. I don't know when, Fabiana, Have we started?
Yes.
Okay, we have started. Okay, all right, and we have the brochures and the policies and things like that. And good luck to all of us and to the families. When there's overwhelming illness, not responding to life-sustaining intervention. For example, you have a congenital diaphragmatic hernia, early onset, hypoplastic lungs, pulmonary hypertension, not responding to treatment, and your SATs are 40%, 30%, and you're not getting anywhere. That might be time to talk about palliative care. Okay, then where long-term quality of life is being questioned by the team or by the family, we have differences of opinion amongst us and also amongst family members. So that's very difficult situation. That's why we need the experts to help us. And I put here as the last line, if we have a very complicated case, there is the option to consult the ethics people, because they can help a lot in terms of resolving the conflicts among team members, among family members, etc. I will now, there's more challenges to the effective palliative care, implicit expectations of families and providers of care, misconception that palliative care is synonymous with giving up or doing nothing. Really, it's not synonymous to that. Uncertain short and long-term prognosis. And sometimes the pain and symptom team members are consulted late. So it might be difficult at that stage for them to get involved when we're already in the midst of the palliative care plan. So it's good to involve them early if the parents agree that we consult palliative care or the ACPM. Okay, not TCPR yet. Internal conflicts of wanting the patient to leave and yet you want them to die quickly. As I said earlier, there's a balance. What's the correct answer? Unfortunately, it's not in black and white, it's gray. Okay, now I give the floor back to Simone to talk about the palliative care service that is very helpful to us.
So just like you guys work as a team, I work with five fabulous physicians. Dr. Bruce Barton is the section head for our team. And then Dr. Nadine Gilroy, Dr. Susie Pinnick, Dr. Robin McClure, and Dr. Tanya Borchers. And so they all come with great experience, and we definitely work as a team, as you've seen us usually all coming together. So, and we're available for consultation or partnership or whatever you sort of feel that you need. And I know sometimes it doesn't make sense to introduce us to the family, and it makes more sense to just as a team kind of have an idea of what are the next steps moving forward. If it's kind of later in the game or, you know, things are a little more tense and it just makes sense to have a smaller group to meet the family. We often are also involved with team or family meetings when there's maybe a hope that there might be a bit of a switch in the approach to care. And I think too, especially in the neonatal environment, time. Sometimes that issue of time, we as a healthcare team really wish that things could move along, but the family really needs to settle into the reality of the situation with their baby. And sometimes that may be a few more days than we would like in terms of them getting to a point where they're realizing what's going on with their child, right? And we just have to try and guide them through that. And I've seen some situations where I'm just like, let's just give them a couple more days. I think they'll make it there, right? Like, and then everybody like they do, right? But it's just, it maybe is a little bit distressing, but at least as a staff, you know, you're talking about these issues, the family's thinking about them, they're percolating on them, they're deciding how to proceed. And I think the topic of, or the word uncertainty is huge in your population. When you have babies who you really don't know how this will go because there's never been a case like it before, right? So, and it's really hard to prognosticate in a lot of ways. So you're not alone. And hopefully we can all work together to try and figure out what is best for that family. So when we do talk a little bit about decision-making, having those family meetings is kind of a crucial part to how things play out. And so it's really an important thing that we realize it might not be just one meeting. It might be a series of meetings. It might be a lot of meetings, like daily meetings, maybe even, right? In terms of just what's happening today. What are we worried about today? What are we hoping changes? What if it doesn't? We need to meet again tomorrow, right? So setting these very kind of clear expectations. It's important to have all necessary decision makers present. I also think it's really important to have pre-meetings. So if you have several specialty areas involved, like neurology, surgery, neurosurgery, you know, to have them all at the table and everybody sort of figure out before the meeting, before the family comes in, what do we know? What do we not know? Is there information we're gaining? Is there a possibility of gaining more information or not, right? What are still remain some of those uncertainties? Can we figure out them? Can they be more certain? Can they not be more certain? Who's going to lead the meeting, right? Who's going to talk about each of their pieces so that everybody knows what's going to be said? It's the worst thing when you're in a meeting and then suddenly something comes out from left field and everybody's like, well, what are we talking about now, right? Like, at least if we know that these are some of the options that are going to be presented and we all know. And often we go into a family meeting, I think we also have to realize that a lot of times it's without an agenda. We may have an agenda of like, we want to get them to agree to do not escalate care, but that may not happen, right? It may just be that they hear some information again for the 5th time, you know? And I think like we do sometimes have an agenda, but that we are able to put that aside and just see how a family meeting goes. Because sometimes we have an agenda and we think we'll never get there. And then the family agrees to say, you know what, just stop everything, right? And we're kind of like, what? Like, you know, so they're almost, you just never know walking into a family meeting, sort of what's going to happen. So I think too, if now that we're sort of past this whole COVID piece of not being able to have elders there or parents, or, you know, I found COVID, that was one of the things in terms of family meetings, is that lack of extra support people for parents who can hear what's going on, who can support the parents, you know, whether it's a friend, a family member, an elder, or whatever. Now it's so much nicer to have those supports and really consider that when you're, and especially from a perspective of like, who does this family need here? Speak clearly and directly. And I think we all, when we don't know what to say, we just keep talking, right? We keep talking about things and we make things way more complex than they need to be. And, you know, there's a skill and an art to having a really good overarching discussion about what's going on without basically putting people to sleep in a family meeting, right? So I think it's like, what's been happening, what's happening currently, what are we looking at information that we need, how do we proceed, right? And allow the family to talk more than caregivers. That's, I would say that's really hard for us, and that's rarely happens. But when we stop and ask those important questions, we actually find out a lot of information. And sometimes then that can help guide the next piece of that discussion. So what do we know about the baby's condition? Don't go into minute details about blood work and today's blood work and yesterday's blood work and 5 weeks ago blood work. You know what I mean? Like, keep it succinct, keep it very direct, keep it very organized. And by systems is helpful in terms of just overarching, just saying, okay, so there are 3 things wrong with your baby. One of them is their heart, one of them is this genetic condition, and the other one is their feeding. I'm going to talk about each of those individually and give you an overview of where things are at, right? And then that just is a little bit helpful to kind of, you know, and then we want to talk a little bit about where we go from here, right? So that the family sort of knows, okay, we're talking about the main issues and then we're moving on. So what do we know? And again, that whole issue of uncertainty, which is huge. And I would say, especially prenatally, like, is Molly still on? I'm not sure. I would say that's probably one of the hardest things when we're doing prenatal consults, is that uncertainty. So the uncertainty with the trisomy 18s and then maybe a bit of a cardiac defect, like, are they gonna survive delivery? Like, it's, you know, they could die in utero, they could live 2 years, right? Like, that's a big difference, right? Uncertainty becomes a bit more certain when it's a child with Potter sequence, and we know that their lungs are underdeveloped, but we cannot ventilate them. That really would not be offered by neonatology, and that they likely will die within minutes to hours. That's very different, right? In terms of how we might approach that. So if you have had a chance to be in the fetal assessment unit, you know, like, and you go to the delivery room, because a lot of times we're like, we shall see how things go. If your baby is vigorous, we may consider this, right? Like, so it is a lot of uncertainty, but it is that preparation for some of those uncertainties, and we know what they might be. We know that they're going to be the lungs, we know that they're going to be the heart, or we know what potentially could be causing some issues. And we have to be honest about that. Baby's response to the treatment they've already received, how likely are they going to be able to respond, and interventions that we're not offering yet, or if there's other options for that potentially. What are our goals? Can those goals be achieved? So if they say we want to get our baby home by next week, unrealistic goal most likely, right? But you know, what might that look like? And is that an achievable goal? What does the prognosis mean? So if they've had previous losses, right? If they've had a child die before, if it's a genetic condition that runs in their family, they may have had somebody else in their family, right? So I think also asking them about what is your previous experience with the healthcare system? What is your previous experience with death and loss? Can really help you to know, oh, this is why they're feeling this way, right? Or I need to address certain issues because this is what they're afraid of. And then those potential paths of care, which sometimes are difficult to know those paths when there's a lot of uncertainty, right? But being honest about what might that look like, and what's our choice and our path for right now, and when do we need to meet again, right? Because sometimes you need to meet within a few hours, sometimes you need to meet within a few days, sometimes you need a week to make sure you can see if those interventions actually work, right? So it just depends on the scenario and the situation. And then ongoing, and like, how does that family want to be involved in decisions? I also think when we ask about their hopes, their fears, their values, those are really key to knowing the next meeting. How do we address those, right? So sometimes that continuity piece is really helpful in terms of knowing those hopes, fears, and values. And helping families to know, like, what can they request? Some of them don't even know what's out there, right? So talking about what are the psychosocial supports for you, spiritual care, is that something you'd be interested in having them come by on a regular basis, right? Like those sorts of things. There's a few keywords that I would say from my perspective have been very helpful in practice. And there's also an actual guideline in terms of a serious illness conversation guide that has been put out by Canuck Place in consultation with Ariadne Labs. So the Ariadne Labs are doing more of an adult look at serious illness conversations, and Canuck Place modified those and made a pediatric one, and then an actual like neonatal one as well. So what I really like, and when you talk about this shared prognosis, there are some really keywords just to keep in your vocabulary and in the back of your mind in terms of scripts that we use that we can, you know, talk about in neonatology. And so they're wish, worry, and wonder. Okay, so 3 really good words as I wish things were different. I worry that we're in a spot where your child is very, very sick. I'm particularly worried about the fact that we can't get them off of ventilatory support. You know, I wonder if this continues and we're not able to get them extubated, how we might see things going. Okay, so wish, worry, and wonder are great words. The other one that I find in an intensive care environment is that sometimes families feel this pressure that they're choosing whether their child lives or dies, right? Because it's like, if I choose to take away this support, I'm killing my child, right? So that's what they're thinking in their minds. And I think it's really important that if you're going to be working in an intensive care environment, that you say this disease has, you know, charted your child's course. we know that your child is gonna die from this. And now we just need to talk about how that's going to look. So we now have some choices, right? So when we don't have choices about whether your child's gonna live or die, but we do have some choices about who might be there, how this might happen, what we might, consider, where it could happen, those sorts of things, okay? So, it's compassion, but honesty, right? And not kind of mucking around with like pretending you're talking about dying, but not really saying the word, right? So I think sometimes despite saying the word, your child is dying from this, it can be very difficult to say. But then that just sets the stage of, okay, and this is not your fault. And then this, we can't change the fact that your child's dying. But now we as a team and we as a family need to figure out what works best for you. That script is written. Now we're just the stagehands, right? Fixing the lights, fixing who's in the audience, those sorts of things. But we need to really talk about what that means. Okay, so sometimes it comes down to that. There is a education session that you can take part in with this serious illness conversation, and this is just the second page, that wish, worry framework and that sort of thing. So if that's something that you're interested in, it is possible on a national level to get this education, and it's something that we as a pediatric palliative care team we're hoping to implement at some point soon. And I sort of see the NICU environment as being top priority for me, because it would be easy to kind of organize and engage you guys. And I think everybody's wanting something like this just to help like all the folks on the team. So that's something that I think in the future we can discuss, because a couple of our people on our team are trained to do the training. When we're looking at care plans, again, looking at the advanced care plan in terms of the guide, in terms of advanced care planning, ACP, C, M, and R, and looking at that, and we, in pediatrics, C, M, and R are kind of helpful guidelines, but then that piece underneath is where we put lots of detail about what families might want or not want, right? And in your environment, I think you have kids on life support. So when you're making them an M, but yet they're already intubated and ventilated, it just seems counterintuitive, but then it would be like no escalation of care, no chest compression, you know what I mean? Like, so it's very different in terms of how you might word something and give that detail. So when we see people antenatally, obviously, there's options provided to the family. And then if they choose to carry the pregnancy to term, then we would likely be involved with neonatology. And like I said, there's been much better collaboration. And I feel as much as we say, like, it kind of seems to be both ends of the spectrum, like palliative care here, neonatology here, there's often something in the middle that we come up with as a plan. And so both our teams kind of integrate well with that. At least I'd say so, Molly. Now that Molly's been basically our consistent person over the last couple of years, it's been a delight in terms of linking together. And that sort of COVID sort of forced us to be more organized, which was good. And I always feel like I don't really see Molly in person. It's like I just expect her on the screen in the room, in the yellow room.
No, I'm on the screen.
I know. You look no different than the past 3 years, Molly, in your office. And I just think too, like there's lots of decisions around that nutrition and hydration, and your kids often are artificially fed. So keeping that in mind and how that works, if feeding is a main issue, that becomes sometimes the crux of where do we go from here, right? If your baby can't feed and doesn't tolerate like NG or OG feeds, right? And how long do we do artificial nutrition and hydration? What does that look like? So like our little kid Begya, right? Who's now in NICU or now in PICU, that might be the issue that in the end becomes her end of life issue, because she's not able to feed suddenly, right? Like we can't give her gut feed. So like why and what does that look like, right? So starting to have those discussions with the family already about, yes, her respiratory stuff's an issue, but her feeding might be that biggest issue. So yes, it's controversial. And I think really case by case, we just sort of, as a team, need to talk about it, need to say what makes sense in this individual case. And that's really what it comes down to for that CPS statement in terms of that. So when we're looking at care that you guys might be involved with, we're looking at high risk delivery room. where you might be the first people to kind of assess which way are we going? Are we taking them to neonatology? Are we looking at a comfort approach? And that can be the very hard part when you're in that recess room and you've been there and you've had to make those calls. And again, it's a team call, right? It's a team effort. And if you have the knowledge of the antenatal discussions that have happened, that's helpful in the context of where you're at. We can be in the mother-baby ward where we have people who choose more of a palliative approach and more of a comfort approach instead of coming to NICU, home, or other locations. We can come up with other locations, let me tell you that. But really for any location, we just want to have good space, good privacy, and your new space here, man, compared to children's, remember where we're like extubating and there's like a baby 2 meters beside, even closer maybe, you know, everybody sees that, right? It just seems so, it was brutal for everyone, right? And then just a way that the family has an ability to call for assistance. If they choose other choices, then what does that mean? Are parents part of that choice? Who do we have at that location? So our team also goes out to the community. So within Winnipeg, so we do home visits, right? So if we have a home death, we're going out to do visits there too. So just in case you think we only are here, we're kind of everywhere. And then also to other locations in the province. So if they're going up north, rurally, to northwestern Ontario, to Nunavut, those are places that we can also facilitate care. And just talking about how that's going to look, right? And anticipate those changes, anticipate the meds we would need. And we have a care plan that we basically say, okay, what could possibly happen? How are we going to deal with that? So when we are in hospital, just remember to remove those visitor restrictions, have nursing assessments as needed, facilitate the family being a family, right? I think sometimes we shift from making something more of a medical event to making it more of a human event. And I think that's what our goal is, right? For any type of death is to make it a human event and make it as less medical as we can. And you're just so used to making things medical that you kind of have to, in your mind, say, what is actually needed here? You know, like, do I need this? Do I need that? Do we need this? Right? Like going through almost everything that babe has in terms of, is it necessary? So when we are outside of hospital, like I say, we can develop a care plan. We can set things up in terms of involving those who are in the community and the relevant resources, whoever that may be in whatever community that might be. And it may be the public health nurse, it may be their primary care provider. They may not have pediatricians, you know, we figure it out. And I find in that rural environment, people are so willing to just pitch in and everybody just says, yes, we can do that, right? Even if they've never had the death of a babe before in their community, they'll be like, yeah, we can do it, right? And so we arrange those services with home care, help with other palliative care services. We can coordinate the communication. We can do that letter of anticipated home death where they have to identify a funeral home, to send to the medical examiner's office. We often send those care plans to Children's Emergency Department if they come there, or their local hospital, or wherever we need to. And then just make sure that we have a really good advanced care plan form signed and detailed, and then have that detailed care plan too. So if we're going outside of the hospital, we need to consider who's involved, medications, and then contacting the medical examiner by that letter, just so that everybody is aware that this could happen at home, right? And so if we don't do that letter of anticipated home death, it would be considered an investigation, and the family could be like separated and basically like questioned by the police, and like it can become ridiculous and horrible and a situation that we just don't want that family to be in. And so as hard as it is for them to talk about this, when we talk about the fact that, you know, you could be pulled apart, you can have police interrogating you, they realize, oh yeah, that's really not what I want, right? And so that's not what we want either. And then did you want to go through this?
Yeah, I think that those are all in the guidelines, so you can proceed to the next one.
Okay. And I think,
Supporting,
yeah, I think
we have
this-
that already.
this is where we have like,
Yes.
the supports for families, right, in terms of resources for families. So there's a lot of resources. There's the pictures, you maybe seen the light, the shadow photographers who volunteer their time and provide free photos to families. There's an annual memorial service that's starting this year in the fall. And then there's other resources too, like a memory walk and Palliative Care Manitoba. Palliative Manitoba has kids grief groups. And then, you know, preparing the family because they really just need to know what to anticipate, who to call and know what sort of they might see, right? Having those rituals and spiritual care present, they're often extremely important. And the family often wants that at the bedside. Trying to have a quiet environment, meet the basic needs without being sort of too disruptive to the family. And although there's not often a lot of options, if there are options and choices, help the family with that because they haven't had a lot of other ability to make kind of decisions that way. Some parents don't want to be present during withdrawal and they choose to leave. And so, you know, then consider how might you as a team kind of handle that? And will there be a team member or two that you kind of switch off in terms of just being there for that baby? And then how might you stop some of those treatments, in what order, when, you know, working through that as a team as well. And just thinking through what meds do you need to have prepared. And then something that you might see if you are in the delivery room, in the recess room, is that intranasal fentanyl, so that we don't have to start IVs on babes, so that if they are distressed, that can be given and that's easily administered. And then preparing families for what they might see. It's not moving forward.
Put it in the center, like in the middle of the, yeah.
Okay, there you go. And then memory making, just
Yeah, these are all in the guideline.
Yeah. What you might want to include in those memories, right? Still,
And
it's being,
it wants to be in the
it's
middle.
being persnickety,
Yeah, right.
just like me some days. Isn't this one? There we go. No,
Just put the arrow in the middle of the slide and then left click.
yeah, I'm trying.
Oh,
Oh, there we go. Now it's finally.
it's a bit temperamental.
Okay,
Okay.
these I think too are key in terms of the impact on the team and the impact on you. And these situations are soul sucking. You know, these are the ones where you go home at night and you're like, now that was a rough day, right? And so just to acknowledge that and to realize that there are going to be some cases that might be harder and that you might need either to talk to a colleague about, you might actually need professional help, you may actually need to just see a counselor, access some of those services that are available to you, because if you don't do that, the residue from all of these will eventually break you apart. And so that's just not helpful. And just recognizing that these are tough, right? And saying it out loud sometimes is all that needs to be said, or having a little bit of a debrief as staff. Like if you say, that was a real hard one for me, did anyone else find it hard? Can we just have like half an hour to talk about that? And in some avenue or venue or whatever, I think is important to recognize, because you're likely not the only one on the team that's struggling with that. And I've seen, when I come in and I can kind of like palpate the distress of the team, I'm like, this is not an easy one, right? And we've had cases too where we've debriefed and there've like literally been nurses weeping, and I'm not exaggerating, you know, saying I felt like I was torturing this kid, you know, all of these things that you do need to kind of consider your feelings, but also the feelings of the rest of the team. And say, like, did we do a good job? What could we do better? How could we improve that? And there are some times where there's just families that are difficult to move forward in terms of trying to get them to a point where they agree to not continue extensive interventions, right? Anyway, there we go. So there's also critical incident stress debriefing, et cetera, et cetera. If you have questions about things like organ and tissue donation, you just contact organ and tissue donation people through HSC paging. They're great, and their rules and regulations always change, but really I don't think there's a lot that can be donated from under certain kilograms, and so that's pretty much doesn't apply to any of your population, but worth asking, right? And if families are asking, then getting that answer. Autopsies are not required necessarily by the medical examiner. if we really know what's going on. Every child death is reportable, because the medical examiner provides a report every year on pediatric deaths. So we do, even if a child dies in the community, at home, we have to call the medical examiner, someone from the team, and say, this child has died at home, blah, 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 because it's a reportable death. Most of them don't need to have autopsy. Some families want either a partial or full autopsy, or genetics want something, so that's something to consider. And in the end, if the medical examiner considers that this needs to be one of their cases, then they have the authority to do an autopsy.
Okay,
All right.
I have 5 minutes for questions. I just have a few slides left. I want to mention this presentation at the CPS last month. There was I think she was a fellow from a French hospital in Montreal, and she presented what happens, where is that? After you send home these babies for palliative care, and they looked at what happened at 2 years. And here is their results. 8 of them had CP. 8 of them had moderate to severe neurodevelopmental defects, and 8 had, they call it normal or mild neurodevelopmental defect, but 4 of those had gastrostomy feeds and 4 needed rehab. So I don't have all the details here, but I thought that's important. There's another textbook that I discovered from the U of M website. It's coming out June 11. I just ordered mine, and it's actually, I read these things as an introduction to the book. I thought it might be a good guide for us. That's done. Okay, here's the WHO definition. So I won't even read it to you because it's too long, but all the papers, important papers, talk about this definition in different forms, okay? But this is the gist. And then this is some more.
Yeah.
You can see why I didn't want to put you to sleep. And then for children, there's also a long list here. And I just meant, this was an old slide, but you always hear hospice care, and that's what it means. And my message, we are a team no matter what. Okay, we say babies but we lose some, unfortunately. And as we said, death is part of life. Some babies die, most of the babies we save are okay. But there are some difficult cases, like in the case of neonatal palliative care. Just a few photos. Here is Aspen. It's a team. You have nurses, you have fellow, you have pharmacy,
I can
etc.
name them all.
Yeah,
Everything, eh?
even with the mask.
Yeah,
Yeah, I think this is Lorna,
yeah.
and I can't tell who Siwa. And this one is Caitlin.
Yeah,
I can't tell here.
that's the only one that I'm like.
Yeah.
She's a
Who?
dietitian that went to.
Carly.
Not Carly, the other dietitian that came, now she was
Oh.
pediatric.
Yeah. I think
Oh,
right.
okay,
It was
all
for
right.
Carly's maternity leave.
All right, okay. Then here's another one,
I know
Abrar.
those two, yeah.
Our unit
Tertia.
assistants, they're very helpful. We need their help, especially for all the paperwork we are doing.
Yeah.
And then, there's maybe.
Maylene, yeah, this one, yeah.
Sometimes we go out to eat. Molly, there you are.
You exist in person.
Trish.
Celia.
Amir is here. Yeah, and Hanifi. And last and best slide, our friends in the palliative care service.
You have a picture of
Da-da-da-da.
Where the heck did it? What was that at the conference?
At the palliative care
Oh,
conference. Yeah.
totally, yeah.
Yeah, this is Robin, right?
Yeah, that's Robin, yeah.
Robin, McClure?
Yeah.
Okay, and this is our famous
You
Simone.
look fantastic.
Yeah,
in that.
and there's actually
At least
a
have my eyes
palliative
open.
care conference every September,
Yes.
2 days in Canada Inns.
Mhm.
And I attend that every year, even if it's adult,
I
but
know.
sometimes there's pediatric.
I always look forward to seeing.
Yeah, but that's where they discuss all the maid and things like that. It was so, it's a bit confusing.
Do you know what the dates are this year?
21, 22, I think.
Yeah,
Yeah.
September.
September.
Yeah,
Yeah.
Thursday, Friday.
Yeah, I've enrolled already.
Mhm.
Okay.
Me too, but I'm
obviously,
sharing
this
it,
is
so I better
my-
know when it is, hey?
Yeah, that
21,
is my,
22, yeah.
Area of interest for newborns, and let's hope we continue to do a good job that we are doing as a team. And questions? 1 minute, any questions?
Just one simple
Yes.
question. Especially coming from low resource community, in my home country to here.
Yeah.
So how to negotiate when there's some extreme measures that can be applied in some other centers which is not available? Like, for example, the example you mentioned, Dr. Caces, about congenital diaphragmatic hernia with no saturation.
Mhm.
And many advanced, like veterinary care centers, they will offer the ECMO.
Yes.
And the mortality will be like comparable to those who are making it without being on ECMO.
Mhm.
So how to balance this? Because this may be perceived by the families as like, okay, your center is not advanced much or
Mhm.
to give the treatment to my child.
Yeah.
So I wonder how would we approach this?
Yeah, don't take that.
Do we have the freedom to mention that maybe in other parts of the world or other centers, your baby may make it, but here with the limited resources and we are unable to advance further, we are stuck now and your situation, the baby's situation is
Yeah.
going.
Mhm.
So just like if they're stuck where they are, right? Or if the family says, we want to go home, then we say, okay, but that takes out this many options for care, right? Like, so you just, I think you have to acknowledge it because they will find it, right?
Yeah.
They will find it elsewhere and just say,
In the internet. they will
on the
find it.
internet, they'll find it, or they'll talk to family members, or they'll talk to
Yeah.
other people, and you can say, in our facility, the limits of what we can provide is this. Unfortunately, I know that there are other options elsewhere,
Yeah.
and we can't offer that here. I'm really sorry about that. Knowing all of this, here's where we're at, here's what we can do, and this is where your child is at right now. And this is the furthest that we can go, and if we get to that point, we will have more discussions about what to do at that point. Yeah, so name it, call it, because they're gonna find out anyway.
Yeah.
Yeah,
Yeah.
and do it compassionately, right? Because you can say,
Yeah.
I really
Yes.
wish, again,
Exactly.
wish comes in, right? Wish
But
that
we're
we could
concerned
do
that we
that,
don't have
but
that.
considering that we don't have that,
Yes.
I wonder what steps you would like us to take.
Mhm.
My hope is that we can use this to get your baby to survive.
Mm.
If that doesn't happen, we'll have further conversations.
Yeah.
Mama?
Just 2 comments about it. That was
Yes.
a spectacular presentation.
Okay.
Please don't-
I'm glad no one fell asleep.
No, no, no.
Despite turning the lights down here.
Just a comment, and maybe Dr. Pastolo knows more. Now, when other provinces started challenging the limits of viability, started resuscitating babies at 22 weeks, Manitoba was not there yet. Maybe a
Yes.
few mothers were questioning why.
Mhm.
Now, this is just a comment, maybe Dr. Pastolo can further comment. The other thing is, I feel like a lot of, like, because of the turnover of NICU staff, sometimes there's rapport that established with the family.
Yeah.
And then we reach certain things. I think involving palliative care team, center management team, to kind of be that familiar picture that bridges the way between attending to attending. Because sometimes the family is on board with end of life decisions, but then a new neonatologist comes on.
Yes.
Again, it's a
Yes.
clinic.
It's a system, right? It's a
Yeah.
system
And
issue, yeah.
it is a dynamic baby who's changing,
Yeah.
right? It might be new findings that weren't there before.
Yeah.
So that kind of puts a pause on the previous plan, like I've seen it many.
You've seen it many times. I've seen it many times too,
That's
right?
for the baby,
Yeah.
that's, I mean, the
Yeah.
family.
So how do we, you knowing that you have that system of turnover, right? I think there are sometimes when you have to do almost a heap more of work in that transition. Sometimes it may require you staying and coming to a meeting the next day when you're off service in order to have that continuity. And I think sometimes you just need to be aware of that as an attending.
Yes.
So, and I know that's not how you function, but in these situations, like, sometimes you just need to say, I need to do this because. So I've seen it when an attending will be like, I will either remain on for the next day, knowing that the death's gonna happen. Like, didn't quite happen on their time, and then they're like, I don't feel right handing it off to
Yeah.
somebody else. I don't feel that that's, that should happen, right?
Yeah.
And so I think that's a lot of figuring that out, but you're right, like if, I'll be honest, like there's sometimes I'm at family meetings where I'm the only person who's consistent from one week to the next week, because all of the attendings have changed on every specialty service. And then I'm the only one who can say, remember how we talked about this last time? So that I'm like,
Yes.
kind of roping it in a bit, right? Like, so it is, that continuity piece is crucial. And I think if you identify that, then you have to say, how can we make it so it's better?
Yeah.
And it may be that you need to just give a bit more, or you need to meet again with, and have almost like a
Yeah.
switch over of attendings with a family meeting. Like, I don't know, sometimes we need to be a bit more creative.
I agree with that, because I've had situations when I was a bedside nurse where it's like, the family isn't on board yet, we know the death is going to happen.
Yes.
And it's like, and I could remember being like, okay, I know they're gonna say, no one's talked to us. And
Yes.
there's already been the conversation, so.
Yeah.
As the bedside nurse going to my charge nurse, going to the doctors, going, you two need to talk and be present.
Together,
Mhm.
yes, and hear it, right?
So
Like,
that you both know that the conversation has happened.
Yeah.
And to help the
Yeah.
family get there, so that
Yeah.
no one's saying.
Because
it
there's
didn't happen.
often nuance in some of those conversations that you
Mhm.
can't write out in a note,
Yes.
you know what I mean? Like, you can only like,
Yes.
okay, no one's gonna read my note if it's 5 pages
Yeah.
long, right? Like, so there's nuances.
Mhm.
And especially in those complex ones, I think we do as a team need to realize they may require just a little bit more.
Yeah, that goes to the other big C, communication, really, communication. And not to be withholding information from the other person, just be open, honest. And discuss what happened during your week. This is where we are.
And knowing too, I think, sometimes you're like, why didn't they get them further? You know what I mean? Like, but it's not that, like, it's like, as a team, we've tried, right? And I think we have to give each other compassion too,
Yes.
because, there's only so much we can do until the family realizes that this is unfolding that way.
Yeah.
And I also think it's hard too, like if you're caring for that baby, like nurses are taking care of the baby, and they get other nurses around them who aren't taking care of the baby, that are
Judgy.
being very judgmental,
Yeah.
putting in their 2 cents when they haven't like taken care of the baby, haven't been part of the conversations, makes it that much harder on us.
One time, though,
Yeah,
just,
and so I think as an attending, you may, like I say, sometimes I come in and I feel the pulse of what's going on and you're like, holy smokers, like anxiety and everything on everybody in this team is like up here. As an attending, your job is to also help make sure everybody knows why you're doing something, what the goals are, all of those things. Which sometimes are hard when there's switch over of everybody, but we will stop talking because it's not
Well, do you want to set them into,
Yeah.
that we can bring them into the picture too, if we.
Oh, if we stay here, if you guys stay here, I could.
Oh, I see what she wants another, she picture taker, obviously.
Yes.
Seriously,
Oh, there you go.
okay.
Okay.
Guess I gotta smile.
Then we'll take over.
Yeah, exactly.
Okay, come on.
Closer.
Okay. And then, if you want to take for us, yes.
Yeah, us.
There we go.
With this screen. Yeah.
Yeah, part of it.
They say 1, 2, cheese.
Back up.
Again, 1, 2.
Okay, great.
I'll do the second with the nose.
Oh, okay. Oh, nice.
Awesome.
Very nice.
And, okay, regarding your question about the 22 week. So I'm not aware of any families requesting or moving to another province to deliver my baby because I am less than 23 weeks when
Yeah.
that happened.
Yes.
But I hear, for example, in Ontario, that I think one of the hospitals started before the other ones families requested at that point to be transferred. I think was Mount Sinai
Mount Sinai.
that was offering,
That-
and people was requesting to be transferred.